Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sakia. Today, I'm joined by Professor Rosanna Peeling, Chair of Diagnostics Research at the London School of Hygiene and Tropical Medicine and founding director of the International Diagnostics Centre, the IDC. Trained as a medical microbiologist at the University of Manitoba in Canada, the good doctor served as research coordinator and head of diagnostics research at the UNICEF, UNDP, World Bank, World Health Organization special program on research and training in tropical diseases, which is a bit of a mouthful, and it's thankfully abbreviated to TDR. We'll be mentioning that. She's also served as chief of the Canadian National Laboratory for Sexually Transmitted Diseases, STDs, and has also contributed to WHO guidelines for HIV, hepatitis, dengue, and STDs, as well as advising on COVID-19 diagnostics and global health strategies. She was the first woman to be awarded the George MacDonald Medal by the Royal Society of Tropical Medicine. As if you couldn't guess, this is one very, very accomplished professional. Outside of work, astonishing to think that she has any time outside of work, Professor Peeling is a certified tennis teacher. I know where I need to go for some help. And she loves reading, traveling, and hiking. So welcome to the podcast, Professor Rosanna Peeling. It's an honor and a pleasure to have you on the podcast.
Thank you. It's lovely to be here. I love to talk about diagnostics anytime.
Fantastic. And good Lord, as I went through your CV and all the references and such like, there was just so many things. But I have to start with something a little bit off in left field. I understand that you once met the Dalai Lama on a plane from India to London, and he had a special message for you. Can you tell us about what happened, what he wrote to you, and the rather interesting piece of paper that he wrote on? I love
Yes.
this story.
That was one of the highlights of my career, I think. So on this flight, after everybody was in their seats, and I noticed there was a block of 6 seats across the aisle from me that were empty, even though it was a full flight. And then when everyone was ready with the seatbelt buckled in, then the chief steward of the flight let in the Dalai Lama and his travel companions. And they were seated right across from me, but because it was a very late night flight, so everybody immediately went to sleep. And so in the middle of the night, after I went to the washroom, I was coming back towards my seat, and I noticed that his light was on. And as I was approaching my seat, he looked up and he smiled and nodded at me. So I thought, oh, that's a sign that I could talk to him. So I knelt down on the seat beside me and started speaking to him. And he was very kind. He immediately took my hand, shook hands, and he said, "Are you traveling for pleasure or for work?" And I said, "For work." And he said, "What kind of work do you do?" And I said, "Sexually transmitted diseases." And he immediately said, "That's very important for the prevention of HIV." I was very impressed. I didn't know that he would know that because we try to teach that to health programs, right? And he said, "Would you like me to write a blessing for your work? Because that's very important." And so I went to my seat, got out my notebook from my backpack, and turned to a fresh page, gave it to him. And he wrote a prayer and a wish. And it said that he wished that I would always do good wherever I am and whenever I work, and that I would always be able to conquer the bad and be able to see that the good triumph over the bad. And so he explained that to me. I thanked him. I went back to my seat and I looked over the prayer again. And then I saw that on the other side of the page is all the information about how bad resistant gonorrhea has become. and, and how we must, do something about it. And so I think resistant gonorrhea got a special blessing from the Dalai
Oh,
Lama.
it's a it's a lovely story. I mean, anyone who's familiar with the Dalai Lama and the history of that position since I think the 1950s when he was
Yes.
exiled
Yeah.
um, to India. It's fascinating, and I've sat next to some interesting people on airplanes over the years and in airports, but never you knock me into the you knock me off the field with that one. That's amazing. I presume you have it somewhere special,
Yes, I
the
I had
prayer.
it yeah, I had it framed, yeah. Yeah.
Lovely,
With
lovely.
the
I'm sure
gonorrhea
that's a
notes
very
on the other side.
you should have it on a double-sided thing so you could turn it over. So, Rosanna, tell us what first got you interested in medical microbiology and diagnostics?
Well,
What was
the
the origin
diagnostic
story?
yeah, the diagnostic part comes later, but in terms of getting interested in microbiology, it was quite, by accident. I was, studying at University of Toronto, doing a double major in, plant and animal physiology and biochemistry, and after I've, uh signed up for all my required courses, I had a small 3-hour credit course that I needed to take. So I was looking around for something that I could do, and this course in microbiology caught my eye because it was a science course designed for art students who has to take a science elective, and it's what they call a terminal course. It's not meant to be followed as a career or a major. And the fun thing is that you get to go on field trips to breweries to see how yeast work in our everyday lives. And so it was very good. And the lecturer was really especially good on the two lectures that we had on the infectious diseases. And that really caught my interest. And so I changed all my plans. And the following year, I took courses in microbiology and ended up doing a master's in microbiology and then a PhD.
It's in it's interesting, isn't it? Just one lecturer
Yeah.
one speaker, and I had the same experience of one teacher who just captivated me, and took me down the path that I went on. So I mentioned the IDC. Can you describe the work of the IDC and its goal to advocate for diagnostics, improve health, and combat antimicrobial resistance, which is an existential threat, is it not?
Yeah. So I think the origin of my establishing the International Diagnostics Centre is that when I was working at WHO, TDR, uh, we because WHO is in the business of convening experts to develop guidelines, it cannot have any conflict of interest in terms of working with industry. And so it was always us and them. But as we know, in public health, I mean, we are, we cannot just ignore the private sector, right? And especially we saw during the pandemic, without the private sector to as develop all the tools, we have nothing. And so when I went to the London School, I decided to establish a neutral platform so that we could have meaningful interactions with the private sector, specifically actually to tell them the kind of test that we want, right? Because there's often a disconnect between what is produced by industry and what the kind of tests that we want. So it's meant to provide a neutral platform for these interactions to to advocate for the value of diagnostics and to foster innovative research to accelerate access to quality assured diagnostics. really the access pathway has been, very slow, as you know. And so, we try to do whatever we can to advocate to governments to have a more accelerated pathway for access to diagnostics. Right now, before COVID, it was taking 5 to 10 years, and the access is not always equitable, as we found out. Yeah.
Right, right. So, well, you mentioned diagnostics. Without diagnostics, we can't really have preventatives like vaccines or treatments. They're essential for public health. I've been involved in some in vitro diagnostic startup companies, and it's always harder, in my experience, to raise money. It's always harder to raise interest. It's always harder to get people's attention and focus with diagnostics, even if they're, phenomenal things that could address real major health issues. Why is that?
That's the story of my life too. It's always so hard to talk to donors about investing in diagnostics, talk to governments, because I think most governments consider diagnostics to be a tool and not a life-saving commodity. And so, it's really, I mean, governments are very reluctant to spend money on diagnostics, uh, because they perceive that it's not saving any lives. But can you imagine that if we don't have an HIV test to screen for people who are infected early and treat them, so that we could interrupt the chain of transmission in a community? Can you imagine if we don't have that? What would the HIV epidemic be like? And look at COVID. So COVID has really, after years and years of advocating for the value of diagnostics, COVID has really made a difference because governments start to realize that without diagnostics, we don't have any means of stopping the transmission. We don't have means of telling them who they should be treating. And also, the diagnostics provide data for surveillance to see, where the outbreaks are, the extent of the outbreak, and if there's a vaccine for, say, for example, for cholera or for meningitis, using diagnostics to define the extent of the outbreak, where the hotspots are, really allows the vaccine deployment to be a lot more efficient and also very cost effective.
Yeah, very, very, very much so. So, in your work with WHO TDR, the mouthful that I I laid out at the beginning, you focused on evaluating diagnostics for low resource settings. Can you address some key factors that make a diagnostic test effective and practical for use in those settings? I would imagine it's things like obviously it can't cost a lot of money and it can't rely on extremely expensive analytics. The floor is
Yeah,
yours.
so in low resource settings, I think we all understand that in addition to inadequate funding to buy expensive diagnostics, is that most of these settings would have the patients would have inadequate access to labs. And traditionally, labs are where you do diagnostic testing. And so when I was at WHO, I started talking to donors about the kind of tests that we need. But it's always a mouthful. I said it has to be affordable, it has to be accurate, it has to be, user friendly, because we can have supply chain that required refrigeration, etc. And so at one coffee break, talking to a bunch of donors, I coined the acronym ASSURED to stand for affordable, S for sensitive, S for specific, and then U for user friendly, in that it could be done in a few steps. And then R for rapid and robust. Rapid meaning under 30 minutes, and then robust meaning it doesn't require refrigeration and can be stored at room temperature for a long time. And then E for equipment free, preferably, or just a small piece of equipment, and then deliverable to those who need them. And so Assure became the acronym that WHO is still using today. So we published this acronym in 2004 in Nature Reviews Microbiology. And 15 years later, in 2019, Nature came back to me and said, "Well, did any tests pass the word, the acronym assured?" And I said, "Yeah, HIV tests, malaria tests." But they said, "Does the acronym still apply today?" And I said, "Very much so. We still want the three A's diagnostics: affordability, accessibility, and to be able to have accurate diagnostics. But we can now, with the technology we have today, we can have the diagnostic linked to real-time transmission of the data, digitization of data, so that you could have immediately a dashboard of where we are with regard to infections and what do you need to do. And then E would be, I wanted it to be equal friendly, because can you imagine millions and millions of um, plastic cassettes being used and discarded in many countries? But my co-authors on this paper wanted ease of specimen collection, because if we argue for tests to be done at any setting, then we cannot have a trained person taking the sample. And also, if we advocate for self-tests, as we did during the COVID pandemic, self-testing, then it has to be, a marker. The diagnostic test has to have to test for a marker that could be easily collected, such as in urine, in saliva, even throat swabs. Yeah.
Right, right, right. Um, I would imagine that the advent of telemedicine nowadays makes it easier to do consultations, and AI probably could play a role in interpreting these data, and so that you can deploy tests and the vaccines that may be associated with them in a more judicious manner. I remember hearing years ago that CDC, the Centers for Disease Control in America, used the zip codes of where people were searching for what are the symptoms of the flu to work out what the hotspots were in America and distribute vaccines accordingly. Absolutely fascinated me that
Yes.
that
Yeah.
happened.
Yeah.
So you established the Canadian National Reference Laboratory for chlamydia. Can you tell us some more about the work you did, how you developed the diagnostic methodologies, and how point of care testing has evolved,
Yeah.
excuse me, since
So
then?
going back to your second question, this is the part where my career became more focused on diagnostics and other aspects of microbiology. So I did my PhD on chlamydia, the pathogenesis of chlamydia. Um, uh, uh, Traditionally, chlamydia is a cause of preventable blindness. It's a cause of trachoma, right? Which in many countries is still actually happening. Now, in the developed world, um, improvement in living conditions, hygiene has really, and also the use of antibiotics have really eliminated trachoma. But in the late 70s, group of researchers in the US and in Finland and other places found that chlamydia is actually a cause of genital discharge. And so it's a sexually transmitted pathogen. And then they also found, when they started to use a chlamydia test to or culture people who are contacts of people who have genital discharge due to chlamydia, they found that a lot of infections can actually be silent. But then over time, we found that repeated infections would lead to the pathogen going up the fallopian tube, and then with repeated cycles of inflammation and scarring, the fallopian tube eventually gets occluded, and so then chlamydia actually became a cause of ectopic pregnancies and tubal infertility. And with that, because that's a very serious sequelae, um, some countries, including Canada and the US, started to have a chlamydia screening program where we want to, because it's a treatable disease with a dose of antibiotics. At that time, it was 7 days of tetracycline or doxycycline, but now it's a single dose oral azithromycin. And so the treatment is easy and relatively harmless. And so the screening program was supposed to be the means to control the infection. And since I did my work on chlamydia and did lots of culture, did lots of antibody testing, etc., uh, they asked me if I would set up a national reference laboratory to set up the screening program. Uh, at that time, at first, it was using culture, but then companies started to develop antigen detection tests. And of course, then we followed. It was followed by molecular tests, and such as PCR. And so then in order to for labs to be able to know what to do, we had to look at the cost effectiveness of each type of these technologies. So I was really working almost full time on the how to use diagnostics properly in a screening program. How to use it, who to use it on, and what do you do with the results. And those eventually became you know, I guess the same template that we would use for other sexually transmitted diseases, because quite often people would come in for one um, for one episode, and when you ask them to come back later to get their test results, they don't bother. And so that's when I started thinking, okay, we need a point of care test where we could immediately have the results and to be able to know who to treat. Um, at the time when we first started screening for chlamydia, WHO was still advocating for syndromic management, which is that if people have symptoms, you treat for all the major causes of the syndrome, which includes gonorrhea and trichomonas. Yeah. So so it was at that time that I really started to think about, how best to use diagnostics.
That's interesting. One aspect of bringing anything to the market is the regulatory process, which just seems to be getting harder and harder and harder. Europe has gone from the medical device directive to the medical device regulation, and I mean, I wish the people in the lay public understood how difficult this is and how expensive it is and how long it takes, leading to implications for patients. I really can't understand why, FDA and others requiring paper forms in this day and age. It's astonishing. So, regulatory approvals take a long time, very complicated. How can global health organizations, such as the ones you've been associated with, and governments work together to streamline this process while still ensuring quality and safety and, addressing the general public's concerns like we saw with COVID and misinformation and all the rest of it?
Yes, it's a big question, and I was very fortunate to be funded by donors like the Gates Foundation, Grand Challenges Canada, and later on during COVID by the Wellcome Trust to look at the issue of regulatory approval and how can we accelerate that, make it more efficient. And so, even when I was at WHO, what we did was we tried to set up multi-country evaluations so that companies don't have to go to every country and do a separate trial in order to get approval. Now, some countries require that you have to have country data in order to get approval. But then, if they are part of a multi-country trial, that trial data could be used. But then, we advocated for harmonization of regulatory requirements. Can you imagine a company trying to fulfill the filing requirements for every single country, which could be different? The language is different. I think regularly they're dealing with over 100 languages, etc. And so it's a really daunting process. And we try to establish regional um, uh, bodies that could harmonize or work towards harmonization. I think it needed something like COVID to really push countries to realize that if they want something cheaper uh, and faster, they need to be able to come together and have at least a convergence of standards for regulatory approval. So that's what we've been working on. And we've made some progress, but it wasn't until the COVID pandemic that we started to do that. But at the beginning of the COVID pandemic, when the rapid antigen tests became available, which is something we all need because molecular tests was not fulfilling the testing needs that we want, and it was taking too long. And also, the molecular tests were too sensitive. They were detecting fragments of RNA when people were not infectious. So we needed a test that is a public health tool to tell us who's infectious, who's at risk of transmitting. And so when the tests were finally endorsed by WHO and CDC or FDA as for emergency use, companies come to me and said, we still have 60 some countries wanted independent trials. And that number rose to 92 in the following week. And so, even in a public health emergency, the regulatory authorities are still demanding individual. So I think it's something that we need to really come to understanding. If we organize these multi-country trials, um, what we got the regional groups such as the Africa CDC, ASEAN, and in Latin America, there's a group on regulatory convergence. We got them to come to the table with policymakers from their country and agree to the protocols of how the tests will be evaluated and where they would be evaluated, sample size, etc. So that when the results are available, then they could then easily judge whether it's acceptable or not, and not take months to do it, right? Because they
Yeah.
agreed to the protocol already. And so we've made some progress because of the COVID pandemic, but hopefully we won't slide back. We will keep going.
Yeah. And of course, one is doing all this within an environment where there's, I'm not a huge fan of the liberal use of social media. I think it's been more damaging than beneficial
Yeah,
in the health space. And you've got all these, it becomes an echo chamber, and there's all these conspiracy theorists, and
yeah.
it's so difficult for folks like you to do stuff. Well, let's talk a little bit about social projects, because I know you've been involved in social innovation projects to improve health service delivery. Excuse me. And can you show an example of how such social innovation helps to increase the uptake of diagnostics, especially in marginalized communities, which I know is an interest of yours?
Yes, I think, I could tell you the origin of how I co-founded the Social Innovation in Health initiative with TDR. When I first came to WHO, we started to evaluate rapid syphilis tests. And as you know, pregnant women, if they are infected with syphilis, would have babies born with congenital syphilis or stillbirth, and it's easily preventable, right? The rapid syphilis test
Right.
is 50 cents. A shot of penicillin is what, 20 cents, and so there's no reason why there should be any babies born with congenital syphilis this day and age. And so the Gates Foundation, after we found out that there are good syphilis tests, the Gates Foundation funded me to try to introduce this test into 7 countries. And it's 7 countries with different healthcare systems, different economic and sort of cultural norms. And so that project was very successful in terms of reaching the prenatal population. But the origin of the infection is not the pregnant women. It's usually their partners, and their partners could, um, could be in some societies men who have sex with men, and because of social pressure, they had to marry, and so then they pass on the infection, and also because of the HIV epidemic, syphilis also became, very prevalent in men who have sex with men, and also in sex workers. And when we try to introduce the rapid syphilis tests to those populations, they were very skeptical. They were very reluctant. And then I realized that we're not speaking their language, and we needed to give them a message about syphilis screening in their own sort of context. And so we started working with the leaders of sex worker groups and men who have sex with men. And we started to uh, actually source a messaging. We decided to have a messaging contest, and so, in certain countries, there are websites where they look for partners, etc. And so we wanted to put those messages about syphilis, the need for HIV and syphilis screening in those websites. And because we started the conversation with them, we started this competition, there was so much interest that the the competition itself was good enough education to actually get the message out. And then we realized that besides the top-down approach of introducing an innovation, we really need the bottom up, because communities have many ways of solving their own problems, and we need to work with them to try to create uh, conditions that fulfill these sort of local requirements. And so, if you think about sustainable service delivery, it's always dependent on the cultural, the social, and economic context locally. And if you don't pay attention to that, then whatever you introduce would either not be taken up or not sustainable. And so that's why I started this social innovation in health to go
Right.
along with technological innovation. Yeah.
No. I'm reflecting on your acronym assured, and it has to be relevant, and you have to be able to deploy things understanding it's not just about the test and the doctor, it's the patient and their acceptance, their community. A very wise friend of mine, Dov Barron, who I like calling out on this, crediting him, talks about um, he uses the term emotional source code about the way people process information. He's an Englishman who lives in Canada, but he's done a lot of work in the United States. And he makes the point that if you were to pull two words out your lexicon that Americans would use to describe themselves, two or three words, they would say things like freedom,
Mhm.
independence.
Mhm.
They're very proud of that sort of
Yeah.
that construct. And he said that he thinks one of the reason there was so much resistance to COVID vaccination and COVID testing is that they were being told to do things, and they don't do well being told. And I've certainly found, I practiced in America for many years and worked with some marginalized communities, and you had to adapt your presentation just like you would if you're talking to a sick child, or talking to a very elderly person, or talking to someone who's hard of hearing, or talking to someone for whom English isn't their first language. We
Yeah.
adapt as physicians what we say and
Yeah.
do. We have to adapt what we do, though. Is that a reasonable observation, Rosanna?
Oh, absolutely, absolutely, because that's the crux of health service delivery, right? I mean, it's not
Right.
like a single recipe that you could apply to everyone. It makes it very hard in when you introduce an innovation, to think having to think about, the social, cultural, economic, sort of context of people, in whether they would, one, um, agree to something like this, and two, agree to how it's delivered, right? And three, agree to actually comply with it for the long term, right? It's asking a lot. And that's where a lot of innovations stay on shelves and never get applied. And so the social innovation part, we say it's the having the physical product, having done all the product development, all the regulatory approval, is the start of the access pathway, and that access
Yeah,
pathway is long.
fascinating.
Yeah,
Yeah,
and often
fascinating.
inequitable. Yeah.
Right. Oh, yeah. That, of course. Yes. So, Rosanna, what are some of the most exciting innovations in diagnostics right now that are at or just over the horizon that you think could be game changers?
I think, well, point of care testing has really evolved, and so to the extent that, you know, um, I think in many families that have multi-generation homes, during COVID, it was a normal thing when you sit down to Sunday dinner for somebody who is always going out with friends to get tested before they sit down with the family for Sunday dinner, right? And so it's become a way of life for us, to be able to have a test that would assure our own safety, and by extension public safety in the home, in the workplace, in schools, etc. So that's really changed a lot in terms of, what is done. Also, besides the acceptance of self-testing, which actually for HIV there are self-testing for HIV, but the company who got the first test approved by the FDA will tell you that they spent 8 years convincing the FDA, the US FDA, to allow them to have a self-test. So, but in the COVID pandemic, it was done very quickly, over 100 countries immediately, allowed self-testing to be done. So that's a major game changer, as to you have now the choice. The other thing is, during the COVID pandemic, many countries changed to allow pharmacies to do testing, or to be the source of tests that people could buy or do their testing there. So that has changed a little bit. So it's no longer you have to go to make an appointment, go to the doctor. And in Canada, after the COVID pandemic, the government has announced that there are 13 conditions, including urinary tract infections, for which you could go to a doctor, go to a pharmacist, and get a prescription. And so things have changed. Technologically, of course, there's been a lot of developments, and with the new faster, much faster molecular amplification testing, the CRISPR technologies for identifying targets very quickly and very early. Um, you know, all that technologically is changing, societal norms are changing, and so yeah, we're in for very exciting times. We just have to fix the regulatory part
Yeah,
still.
we've got to fix the regulatory pathway, and we've also got to fix the way that healthcare is paid for, which leads me on to my last question, which is if you could wave a magic wand and have three wishes for your topics of interest in healthcare, what might those be, Rosanna?
Uh, d- I think the best that I want to wish for, and it may be dating me, but remember Star Trek, the tricorder? Do you know
Yeah,
the
there you go.
tricorder? Where,
Of
you know
course.
yeah, so, I wish that there's a sensor, right? And many sensors have been developed already, but I wish there's a sensor that could tell, the machine your status quo as it is, and then, if anything it's abnormal, it immediately flags it. I mean, we still need doctors because we need to interpret those abnormal results, right? But then it's non-invasive, it's instant. It should be possible, right? With all the computing that we have on hand.
Yeah,
So,
yeah. Well, I know a number of people maintain that they're getting close to, and of course, lots of things are happening, aren't they, with diagnostics like breath, testing breath for a range of things, Helicobacter, all sorts of stuff. So that's wish
yeah.
number one. Do you have
Yeah.
two others? You're entitled to three.
Yeah. So the fact that you can digitize all these changes, and then the condition that is diagnosed by the tricorder can be logged into a central database. Then we have an automatic surveillance system. During the pandemic, well, it was post-pandemic, during the G20 summit in Bali. I was asked, what is your wish for the next pandemic? How can we be more prepared? And I said that every country should think about having a diagnostic system that is completely connected from the reference laboratory to the top, and to community testing in at the bottom of the healthcare system. So it's a system that it is the backbone of the healthcare system. It sits there listening to unusual trends, if it's chronic diseases, or outbreaks if it's infectious diseases, and then quickly alerts people in real time. And because all the testing is digitized, we immediately know the extent of an outbreak. Hotspots can be identified and actually shared. Data sharing is really important, especially for the public, because that the transparency and being able to know what's happening really help the public in playing their part in the pandemic. So the second would be a really good surveillance system where the data could be used for action, public health action, so that we no longer have public health emergency. The third relates to the second, which is that, clinicians typically need to, I always said when I teach clinicians, you need to interpret the test results in your local epidemiology. But how many physicians do you know the local epidemiology of any infections other than maybe flu, right? But if all the diseases, all the conditions are the results are digitized, then differential diagnosis would be a lot more informed, right? You can make a better differential diagnosis, because you would know the local epidemiology and to be able to interpret whether that test result is good. So it would improve clinical management by a long shot.
Yeah. I think we need to do those are all very profound and useful observations. I was talking to some colleagues recently, and they're saying one of these issues, well, there are many issues with the measles outbreak in the
Yeah,
United States at the moment, but of course, that is all due to vaccine hesitancy.
yeah.
But they were saying that one of the issues is the majority of physicians today have never seen a
Never
case of
seen.
measles. And
Yeah,
they wouldn't know a Koplik spot if it jumped up and bit them on the rear end.
yeah.
So we've got a lot of educating to do. I'm afraid that's all we've got time for today, but I think, this is so fascinating. I've written so many notes, Rosanna, that we definitely need to have you back. I'd like to thank Professor Rosanna Peeling for being with us today, and frankly, for everything she's done in a phenomenal career, and she ain't finished yet. Thank you, Rosanna.
Thank you very much. My
So,
pleasure.
folks, oh, it was lovely having you, folks. If you've enjoyed this, and I'd be astonished if you haven't, please subscribe if you don't already on Apple, Spotify, any of the platforms. Leave a review, tell your colleagues. It all helps. And check out the archives. There are hundreds of marvelous conversations in it. Well, the guests are marvelous. I'm just a necessary evil, if you will. And join us next week for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Thanks so much for being here. Please, everyone, stay safe, stay well, stay curious. Bye for now.